Yeah.
Okay, so as I said, if you have any questions as you go along, please do feel free to put them in the chat. We won't be able to answer them necessarily as we go along, because obviously there's only two of us here to help you out. So we're going to spend about an hour talking about some technologies for the treatment of speech difficulties in children with cleft lip and palate. As I said before, my name is Joanne. I'm a researcher at the University of Strathclyde in Glasgow and a speech and language therapist. And we have also Maria, who is also a speech and language therapist, researcher at the University of Strathclyde. Robin, who's one of our researchers, isn't able to make it today. And then we also have our two clinical colleagues who probably can't make it this evening. Unfortunately, Lisa's been called away and Lindsay is on maternity leave, but they are the clinicians that do most of the work with the children and the interventions that we're going to talk about. Okay, so I'm just going to give you a little bit of an overview about speech difficulties in cleft lip and palate. I'm presuming that most people who signed up today know what cleft is because you have a personal connection to a child or children with cleft lip and palate, or perhaps you have one yourself. So I'm not going to kind of dwell on that too much, but obviously if you have specific questions, you can answer them. Then I'm going to outline for you what the current treatment approaches are for speech difficulties in terms of speech and language therapy. And then we're going to focus on our area of research, which is using ultrasound to image children's mouths while they're speaking so that they can use that for assessment and intervention. And then I will just take you briefly, well, actually, Maria will take you briefly through the results of a recent research project that we've just finished up, and then hopefully plenty of time for questions. I'll probably pause about halfway through for questions as well, just so that you've got a chance to ask things while they're still in your mind, but do feel free to put them on the chat as well. Okay. Okay, so why do speech difficulties occur in children with cleft lip and palate? So as most of you know, if you're born with a cleft, that usually means that you have a gap in the roof of your mouth or in the soft palate, which is this dangly bit at the back of your mouth, or often in the lip as well. And these structures are really important for speech. So I'm just going to give you a little example here of somebody saying two different speech sounds, and you can watch what happens to, especially to the dangly bit at the back of the mouth, the soft palate. So this is somebody saying one sound. Okay. Okay, so when that speaker says what's happening here is that the back of the soft palate is down and the air comes up through the larynx, the voice box, and out the speaker's nose when you say so the air flows through your nose. But if you say something like d, we get something a bit different. Okay, so in this, what happens here is that this the soft palate at the back of the mouth comes up and seals off the nose so that the air can come out through the mouth. And if you have a cleft, quite often there's a lot of difficulty with this mechanism. And that makes it really different for children to distinguish, for example, between sounds that are meant to come out the nose and ones that are meant to come out the mouth. So what happens often is that children try to compensate for that or to make different sounds by making the sounds further back in their mouth, especially if they still have any types of structural differences in their hard palate. So because of that, we have two different types of speech difficulties in cleft. We have what they call obligatory errors. These are the technical terms, and these are errors that are due to structural differences. So any difference in the anatomy that children with cleft might still have even after their surgery. So for example, problems with the soft palate. So that can lead to things like air escaping through your nose when you're making specific speech sounds, especially speech sounds which require a build-up of pressure in the mouth. So an example of a speech sound that requires a build-up of pressure would be something like "K," which is a bit like the cork on a champagne bottle, how you build up pressure and then when you release the cork, you get this pop. It's a little bit the same as when you release your lips, you get a pop of sound. And the air will come through the nose potentially when the child's trying to say a sound like that, because their soft palate's not functioning how it should. And that usually needs further surgery. But we also have this other type of errors called compensatory errors. And this is because a child has learned to make a speech sound in a different way to overcome some of those differences in their anatomy. So for example, they might make speech sounds at the back of their mouth instead of the front, even when all the anatomy has been surgically changed, they might still make those because they've learned a specific pattern. And what those children need is speech and language therapy so that they can relearn to make those sounds in a different way so that that's easier for them to say and for us to understand them. So that's what we're focusing on today, is these types of errors, because these are the ones that need speech therapy. So when we talk about speech therapy, we might talk about how we place our articulators, and our articulators are all the parts of our anatomy that we use to make different speech sounds. So we know that when we speak, you can see that I'm moving my lips, so that's one of our articulators. We're also moving our tongues. Your teeth might move up and down, the soft palate's moving, and then the voice box or the larynx in your throat is where the sound comes from. So we need to coordinate all of those different aspects in order to make lots of different speech sounds so that people understand us. So if you have typical anatomy, specific movements and coordination of these different things that we use to articulate will result in specific consonants and vowels. The most important articulator is the tongue. That's how we distinguish most of our speech sounds, is by making different tongue movements. And that's why quite often if children have speech therapy, they are focusing a lot on the placement of where the tongue is in their mouth. I'm just going to show you a little bit of this video that shows you all the different structures for speech. And this is from a website that we have made called SpeechStar, where you can learn a lot more about how speech works. So please do take a note of that website and have a look at it later if you want. I won't play it all, but it just shows you a little bit of how speech, the different speech structures. It is silent. So this is the oral cavity here, is where we talk about different speech sounds, and then into the pharynx, nasopharynx up into the nose, nasal cavities up here, then obviously the lips, teeth. This is the upper incisor and the lower incisor, and then the hard palate is formed of this alveolar ridge and the hard palate, which you can feel with your tongue, and then the soft palate or the velum at the back there. The uvula, that's the dangly bit you can see when you open your mouth. The epiglottis, that helps us swallow, and then the larynx, where the sound comes from. Okay. So obviously with our children with cleft lip and palate, sometimes what happens is they learn these incorrect tongue movements. And why do they do that? And that's because they're trying to make a sound as close to the one that they hear as possible. But for them, it's very difficult to do that. And that's why they learn these incorrect speech sounds. So the therapies choices that we have as speech and language therapists for children with cleft really fall into 3 different therapies. The goal's always the same. So the goal is to change the speech patterns to make speech easier to understand so that the children are less frustrated. And that really helps them to get on better at school and to sound like their peers. So the goal's usually the same, but there's 3 different types of therapy, and I'm going to talk about them briefly, and this is what they're called. So phonological therapy, I'll explain what that is in a minute. And this is a kind of a language or a pattern-based therapy. And this therapy mainly comes from other areas of speech therapy for children with other types of speech disorders, mainly not related to anatomical differences. So mainly children with speech disorders where we don't know what's caused them. And then there's these other 2 types of therapy, articulation therapy and biofeedback therapy, which are much more about speech movements. I'll explain more in a second, then I'll stop for questions. So phonological therapy. So phonology is a kind of a concept that helps us to understand how speech sounds are organized and used in different languages. So phonology is very language specific. So the English phonology would be different from Polish, for example, but it's all about the patterns and rules and how we can apply those. So for example, in English, we have lots of speech sounds which are combined together. So we have lots of words that start with stit and spit and ske, and other languages don't allow those types of constructions. You can only have a single consonant at the start of a word, for example. So phonology helps us to understand these rules. And a therapy that looks at these rules is all about how we make a difference between different speech sounds. So how do we know that T and key start with different speech sounds, and how we can understand how those are used and which positions and words they can be used in, and how they're used across lots of different words. So this will always differ. This will differ depending on the language that the child is learning, of course. So if we have a child, for example, where both the kiss sound and the tis sound both sound a lot like ki, I'm going to play an example now, then this is kind of confusing. So this child is trying to say cape and tape, sorry, tape and cape, that way around, tape and cape. So obviously to us, those are 2 different words, but for this child, they both sound a bit the same. I'll play them now.
A cape, a cape,
You hear them all right, Maria? Yeah? Yes, good. So for that child, they don't really have a difference between those two words or any other words starting with tit and kith. They all seem to sound like they start with kith. So that makes them hard to understand. So if we think about those types of errors as a problem with the rule that those two speech sounds should be different, in children with cleft, that's often what happens is that front sounds like tip, which you make with the tip of your tongue at the front of your mouth, might be confused with sounds that you make at the back of your mouth. And you might treat that with something we call phonological therapy. So you teach the child the rule about front sounds and back sounds. And then once they've learned that rule, they can apply that to lots and lots of different words. So you're not having to teach them each word at a time. You're not even necessarily having to teach them that tit at the start of a word and tit at the end of the word. They can apply the new rule to lots of different words. Obviously, when most of us are learning to speak, we do this very automatically. We don't think about it. It's unconscious. But you can think about it as being a little bit similar to when you're in primary school and you learn about spelling rules, okay, and how to apply those across words. It's very similar to that. Okay. Often, though, our children with cleft know the rules for speech sounds. They know the rules, they just can't make the speech sounds because they find it really difficult to change the speech movements that they've learned due to the differing anatomy that they have. Okay. So in order to think about more speech as a movement, what we might do is something called articulation therapy. And this is a speech therapy that most children in the UK will get who have cleft lip and palate. Mostly it's articulation therapy. So if any of you have got children with cleft and they've seen a speech and language therapist, it's quite often this therapy that they will have had. So it's all about how we move our lips, tongue, etc. to make specific speech sounds. So it really highlights speech movements, and it talks about, you might, for example, tell a child to use the tip of their tongue against their teeth. So it's all about how do we move our different articulators, the tongue especially. So we know that, for example, for that one, you have to teach a child to use the tip of the tongue behind the top teeth rather than using the back of their tongue, for example. Okay, so biofeedback therapy, which is what we're going to talk about for most of today, is a type of articulation therapy. But with this therapy, rather than just telling a child to use the tip of the tongue behind the top teeth, you show them how to do it, okay, in real time, and they can see their own tongue or their own lips moving, and use that to help them to change their speech movements. So a really low-tech example of biofeedback would be using a mirror. So if you wanted to work on getting a child to say "p," for example, that's the sound you make with your lips. So you might get the child to look in a mirror and you might speak to them about closing their lips and opening them and looking in the mirror. And that's a really simple type of biofeedback. Okay, so I'm just going to pause briefly. Has anybody got any quick questions before we move on to talking about how we show children the different parts of their speech organs moving? Nope. Cool. That's all. Hopefully that's been reasonably clear then. If you do think of anything while I'm still talking, put it in the chat. Maria will try to answer it for you and put you on the spot, Maria. Okay, so I just gave you an example of a mirror, but in a lot of the work that we do and other people do, there are other instruments that we can use to show our articulators moving. And I'm going to talk about these now. So some of the main ones that we have used in speech and language therapy are shown up here. So we have on the far left here a diagram that's derived from MRI. Some of you might have had an MRI. It stands for magnetic resonance imaging, and it's a particular technique it gives you an image that's a bit like an X-ray, but it works in a much more complicated way than that. And this is an animation of it. And with that technique, you can see all of your speech organs. We also have a technique here called electropalatography, which uses an artificial palate that goes inside a child's mouth. And then when their tongue touches the roof of the mouth, they can see it on the screen. I'll show you another picture of that in a minute. We also have ultrasound, which is what we're going to focus on today. So I'll explain that in a moment. And then another technique which tracks movements of the tongue called electromagnetic articulography or OptiSpeech. So all of these things are useful, but the ones that are most useful are going to be the ones that we can use in the speech and language therapy clinic. So here's some pictures of some of these ones that are a little bit challenging practically. So MRI up in the top left here, as you can see, this patient's going into a big tunnel. If you've ever had an MRI, you'll know it's very, very noisy and claustrophobic. So that's not a great solution for our children because they're not really going to be able to go into an MRI machine for speech therapy for quite obvious reasons. The one on the bottom here is electropalatography, which actually at one point, all of the cleft palate clinics in the UK used electropalatography just for children with very severe speech disorders. But it's become very expensive because what you have to do is you have to send your child to the dentist or the orthodontist and then get a cast made of their top teeth. And then these bespoke made artificial palates. If you look really closely, you can see lots of silver dots on it. Those are silver electrodes. So when your tongue touches one of those, it lights up on a computer screen. And those palates now cost about £450 per patient. And obviously with children, their mouths are growing. So they only fit for a limited amount of time. Or if your teeth fall out because you're getting adult teeth, that causes a problem, for example. And then we have this technique here called OptiSpeech, where you actually glue sensors onto speakers' tongues. Obviously, not every child wants sensors glued onto their tongue, so that can be quite difficult to use as well. So for these reasons, we really moved on to using ultrasound tongue imaging with our children. So with this technique, we use standard medical ultrasound. So you can see a probe here on the left, and that goes under your chin. And the sound waves from the ultrasound travel through the soft tissue under your chin, and then you get an image that shows the outline of your tongue. And I will show you a couple of videos. It does take a little bit of getting used to interpret the ultrasound, but we find that our children learn to do it quite quickly because they can also feel their own tongue moving. So what you're watching here is somebody else's tongue, but when you're doing this with the children, they're watching their own tongue. So they can also feel the movements and they can hear themselves. So this is just going to be a little example of somebody saying ta, and then we're going to show you how that aligns with the rest of the speech anatomy.
Ta, ta, ta.
Okay, so you can see that you can see most of the tongue just in this view here with the tongue tip on the right and the back of the tongue on the left. Okay, so the children see their own tongue moving. Obviously, the parents can also see their own tongue moving if they want to have a shot. And then what happens is the speech and language therapist helps the child to change their speech movements to make their speech clearer. So they use that image to guide them to do that. So for children with cleft lip and palate, it's often about teaching them to make sounds at the front rather than the back of their mouth. So they will be able to see that on the screen. I'm going to show you a little video now of one of our colleagues. Actually, it's Lindsay working with at the dental hospital. Sorry, not the dental hospital, the children's hospital. They used to be at the dental hospital. They moved to the children's hospital. Teaching one of her children with cleft to use her tongue tip instead of the back of the tongue. So you can see here that she's put some little markers on the screen. So we've got a yellow thumbs up because she wants her to make sounds at the front, which is on the right, and a thumbs down because she doesn't want her to make sounds at the back of her mouth in this particular instance. So this is the surface of the tongue, and it's a little bit like this view that I've just put in of the MRI here on the right. So just a few minutes, I'm just going to play that. You'll be able to hear them.
Let's have a look and see what we can see here. We've got our thumbs up, which is where we want our tongue to go when we're saying the t and the d sound. And we've got our thumbs down, and that's when we make the sound at the back of our mouth. Can you try and see if you can move your tongue so it's at the front of your mouth? So can you try doing the tapping behind your teeth? Okay, wow, look at that tongue go. And where do you think in your mouth your tongue is moving there?
The front.
At the front. Can you show me where do you think your tongue was touching? Toe.
Toe.
T.
T.
Two.
Two.
Okay, now, where do you think in your mouth your tongue was moving there? Was it moving at the back or at the front? That's right, you just pointed to the thumbs up because your tongue was at the front of your mouth when you were doing that. And do you know, when I was listening with my ears, they sounded like good t sounds. That's fantastic.
Okay. I'm just going to show you another video, and then I'll pause again for questions about the ultrasound. So this is one we made recently that you'll be able to see what it looks like with the child in the room. So this is Lisa from a children's hospital working with one of the children that is taking part in one of our projects. I probably won't play the whole thing, but we'll play a little bit. Here we go.
An as, an ease, an os, an os. an ash, an ease, an osh, an osh.
So shall we put some pictures on? So do you want to, you could have a thumbs up or a smiley face or a number. What would you like for where you want your tongue to go?
Thumbs up is good.
Right, okay, we'll put it there. And what colour do you want it?
Green spine.
Fine. Okay, and then we'll put another one for where we want your tongue not to go. So should we just do a thumbs down then for that one?
Yeah.
And what colour do you want that?
Yellow spine.
Fine as well, great. There we are. So we'll put them in place and then you can see. So remember, we've got our tongue tip, which when we're practicing our sound, we want the tongue to be moving towards the thumbs up. And then we've got the thumbs down for where we don't want the tongue to go, which is up at the back of the mouth. So as you know, the sound that we want to practice is the th sound, to try and get it forward for that S. Okay, so you're managing to get your tongue moving forward, but it's moving away from the thumbs down. So it means you're keeping the back of your tongue flat, which is good. Okay, so let's see if you can do it 5 times. Well done. Okay, and again. 5 times again. So let's try that again, and remember what you're trying to do is to keep your tongue flat at the back and moving forward towards the thumbs up, and you're doing really well. So now we'll try it with some vowel sounds. So can you try tha?
Tha.
Okay, see if you can do that 5 times.
Okay, so you can see that she's giving him lots of feedback about how his tongue should be positioned in his mouth, and then there's lots of practice. So with this type of intervention, you need to do a lot of practice of the new speech sounds and also building up. So starting with the sound on its own and then moving on to doing that sound with different vowels. And then obviously from there on, you would move into words. So it can be quite hard work for the children to learn these speech sounds because it does need a lot of practice, but the children really do benefit from getting the biofeedback so that they can see their tongue moving rather than just listening to how they've done it. So there is some studies that use these types of approaches with children with cleft lip and palate, but not that many. So back in I said before that a lot of clinics used to have electropalatography, which is the technique with the plate that you put in your mouth. So there's a lot of really small studies using that technique with children with cleft lip and palate that show that if you use that rather than doing, for example, articulation therapy, that children need less sessions of intervention. So obviously less sessions can only be a good thing because you don't have to take the children so often, and of course they don't get frustrated if they don't have as much speech therapy. And of course it saves money because speech and language therapists don't have to offer so many sessions to each child. In terms of the ultrasound that we're now using, there are actually only 3 small studies so far with children with cleft lip and palate, but there are more studies on children with other types of speech disorders, but we definitely need to do more research. So before I hand over to Maria to talk you through some of the results of our studies with ultrasound, does anybody have any comments or questions? Anything's welcome. You can type them if you don't want to speak, or you can put your unmute and just shout out. That's very welcome as well. Being quiet. Oh, we've got Steve.
Used for?
Very good question. Thank you for asking. So because the children have to practice quite hard and concentrate quite hard, we normally would do it from roughly kind of age 5 upwards. So once they're into school, is the kind of age that we would be doing ultrasound with. We have used the ultrasound for assessment in younger children, so they will use the ultrasound and sit reasonably still and read a few words, or look at a few pictures and say a few words, and that gives us lots of really, really useful information about the child's speech and about the types of mistakes that they're making in their speech. But for the therapy, we tend to find 4.5. If they're a very attentive child, because obviously all children are so different, aren't they? Then 4.5 kind of, some of them will sit and do it from that age, but for the most part 5 up. But it just very much depends on their attention span, really, rather than as much as anything else. That's a good question. Any other questions?
There will be time for questions at the end as well.
Yeah, plenty of time. Thank you. Maria, it's you. Hopefully this still works.
Great. Can you hear me okay?
We can hear you okay.
Brilliant. Okay. So I'm going to be talking about a study that I was involved in for the last 3 years, which was led by Joanne, and that I worked on with Lisa and Lindsay, the cleft specialist speech and language therapists. And as you can see on screen, the name of the study is a bit of a mouthful. So let's see if I can actually say it for you. So we did the study called Mixed Methods Pilot Randomized Control Trial of Ultrasound Visual Biofeedback versus Standard Intervention for Children with Cleft Lip and Palate. So I didn't quite manage. I don't want to say it 5 times over. Let's see. I don't think I can move forward to the next slide, Joanne. If you can move forward for me, please. Or giving permissions. Okay, I think I should be able to do it. Yes. Okay. So that's me moving it. Great. So the study itself, our main aim for it was to see if ultrasound biofeedback speech therapy kind of study would be feasible to do on a large scale. So what we did here was a small version of a study where we wanted to see if this kind of study is feasible. So is it doable? And we wanted to check if we need to adjust anything about how it runs and its design so that we can run a large study with confidence that it's going to run well. And here, the design for this specific study involved randomizing children who have cleft lip and palate into one of 2 groups. So they were randomized to either receive ultrasound therapy, so therapy based on the type of method that Joanne was just talking about, or articulation therapy, which is the standard therapy currently offered that Joanne described as the therapist explaining to the child where their tongue needs to go. And here as well, related to the question that we just asked, the children were aged between 4.5 and 16. So we did also offer it to slightly younger children as well. We also ran an additional qualitative study using focus groups and interviews where we asked the families who participated and some of the children how they found the interventions and what they liked and didn't like. So we recruited 19 children and mostly their families as well to participate in this study. And they first came to me for an assessment. I think a couple of them had to do it over Zoom, but most came to the University of Strathclyde and had an assessment with me. I assessed how they pronounce different sounds across different words and sentences. And I also recorded their speech with ultrasound where it was possible. Then based on that, I, in collaboration with the other speech and language therapists, Lisa and Lindsay, selected a target sound that would be a consonant that they would work on during the therapy. After that, the children were randomized to one of the 2 studies. So there was this whole external organization that was involved in randomizing the children to one or the other therapies. And we ended up having 11 children in the ultrasound therapy group and 8 children receiving articulation therapy. Both groups received the same amount of therapy, so they attended sessions over 6 weeks, once per week. And in each session, the speech and language therapist aimed to get the children to produce the consonant that they were working on at least 100 times. So if you remember from the video that Joanne showed, when Lisa was asking the boy to produce the sound 5 times, so they would do that over and over again until they get 100 trials. After they finished therapy, 1 week later, they came back to me at the university where I recorded their speech again in different contexts. And 6 weeks after the end of therapy, the same happened, back for another assessment with me. And up to 1 year later, we invited the participants and their families to come to optional focus groups. So they were open to everyone who participated, and unfortunately, only some of the participants could make it. And these ran via Zoom. So our aim for making sure that the study is feasible was to ensure that we have collected and achieved 75% of each of the following. So we wanted to reach at least 75% of our target number of participants for the study, and we wanted at least 75% of all of them to stay until the end of the study. We also hope to collect 75% of all of the measures during the assessments with me, and also all of the measures that were happening during therapy, and I'll talk about them in a couple of minutes as well. Also, the speech and language therapist had to record how many consonant repetitions they achieved during the therapy sessions, aiming for at least a minimum of 100. And after that, I collected all of the data and calculated percentage completion rates for each of these aims. So here are our results. And the one thing where we didn't reach our threshold aim of 75% was recruitment. So we were aiming for 40 children overall, hoping to have 20 in each group. But unfortunately, recruiting participants was a bit challenging, and I'll talk more about that later. But of the ones that joined the study, the 19 participants, 8 ended up going into the articulation therapy and 11 to the ultrasound group. And most of the participants stayed. In fact, in the articulation group, 100% of the participants completed their therapy and came back for at least one assessment after that with me. And in the ultrasound group, only one child had to be withdrawn from therapy, and that was a decision made together with Lisa, and was about other well-being concerns that they had about the child. So here are some of the results. So when it came to collecting questionnaires from the families, thank you to all of them for completing all of these questionnaires and recording all of their audio recordings before and after the therapy. We managed to collect at least 75% for each one of them. Then I'm going to move on quickly to completing measures during therapy. So here you see a picture of Lisa. I didn't have a picture of Lindsay, otherwise I would have joined her there on the slide. So we also managed to collect over 75% from all of the measures that we were aiming to collect during therapy. And that included audio recordings of all of the therapy sessions. And also Lisa and Lindsay tallying how many times each child produced the target consonant. And as you can see here in the table, they way surpassed the minimum of 100 repetitions, and actually they managed to get over 200 repetitions in most cases. So I then listened to the audio recordings, and I found out that Lisa and Lindsay had very high accuracy in managing to tally how many repetitions actually the child produced in each therapy session. So now I'm going to move on to the arguably equally or not most important part of the study, which was to ask what the participants thought and what their families thought about this project. So in the second phase of the study, we used mixed methods, which means that we were both counting things and also finding out how participants overall thought about different topics. So we calculated the frequency of positive and negative responses in all of the questionnaires that I was asking all the participants to complete. And we also had focus groups and interviews where our colleague Robin talked to all of the participants and asked them about how acceptable they found the whole experience. So here, again, we were aiming to achieve this 75% threshold limit and to find out whether the families found the process of randomization acceptable, because we expected maybe everyone would want to be randomized to the ultrasound treatment because it's new, or maybe people would prefer to be randomized to the other treatment because it's the thing that has worked for now. So we weren't sure that the participants would like their the way they were treated being decided on random. We also were wondering whether the people would rate ultrasound as being an acceptable technique, whether that was liked by the children. And in the focus groups, we were counting whether there were more positive versus negative themes appearing in what people were talking about. So moving on to the results of that, we calculated the questionnaire answers across all kinds of different questionnaires that we gave to the participants. And we found actually that both groups found the process of randomization acceptable. They were both happy to for it to be randomly decided which treatment they get. Both groups seem to be quite enjoying each of the therapies. And interestingly, people randomized to the ultrasound therapy, 100% of them said that they are happy to continue with this kind of intervention. While when it came to the articulation therapy, so treatment as usual, only about 57% were happy to continue with this kind of intervention, and roughly about half of them didn't want to continue with this kind of intervention. So moving on to the focus groups, where Robin chatted to people in person or in person via Zoom. In those interviews, people shared opinions about all kinds of aspects of the study, and there were several themes that surfaced. And the first one, which you hopefully can see on the slide as being underlined, is the aspect of fun and enjoyment. Participants in both groups enjoyed the therapy and found it quite fun. Also, we noticed that across both groups, families and participants noted that there was improved confidence and improved speech, and improvement in how other people understand the speech of the child as well. So that's something that was observed in both groups. Another theme that came up was also in the ultrasound group. Some of the participants observed that that type of therapy was better than other therapies that the children had received before. And another theme that only came up, on the other hand, in the articulation intervention is that it was a bit boring and repetitive for the children. That didn't actually show up for ultrasound. And one of the negative themes that came across both groups was that there was quite a high burden of travel for both groups. And this will be illustrated with some interesting quotes directly from the families of the participants. So one of them is, if people are quite far away and could maybe struggle to get to you, it would be better if you could meet halfway somewhere. So this is food for thought for the larger study. One of the more negative themes about that came from the articulation group is that it was repetitive and a bit kind of boring. And we had some also really positive comments that came out of this group. For example, I'm glad that Dee got the opportunity and his speech is phenomenal now. You know, there's no barriers for him. And in ultrasound, we have some positive themes as well. So it's been great. I couldn't be more positive about it or recommend it highly enough for those that are interested, if I'm being honest. And it was like a 4-hour journey just to get there and back. So we see here again the theme about travel being quite challenging. This might be also related to the fact of the way the NHS area, how the geography works here in Scotland. And we have also some positive comments, again, from the ultrasound group that relate specifically to the fact that the child could see their tongue move in real time on a computer screen. So I'm going to read them. The fact that somehow a computer she responds better to than telling her, no, you need to do it. You know, it seemed to help her. So that's one participant. And then another, totally agree, like the way he's had speech therapy in the past, he's not kind of understood, whereas showing on a computer screen where his tongue should be. Right, so to summarize the results across the study, we achieved all of our aims apart from one. So we think that the study is feasible, and especially because the one aim where we struggled is related to the number of participants recruited, we think that future studies can mitigate that by involving more than one cleft center and getting in touch with more participants at the beginning. But apart from that, participants stayed until the end. And we received a lot of positive responses in both the surveys and the face-to-face interviews. And participants did enjoy taking part, improved as well. And traveling was the one challenge that could also be resolved by involving other smaller cleft centers. So I see a comment came up. So is this something that is going to be used in other cleft centers? And the answer to that is that at the moment, this was a small study. And its aim was to check whether a big study would be feasible, but we need to run a larger study at some point. And I think I'm going to let Joanne take over from here and see if there's anything to add.
So Maria's right, we do need more research, but there are now 4 or 5 cleft centres in the UK that have the ultrasound equipment and are kind of getting going with offering this treatment. So at the minute, it does very much depend on where you are, but there's definitely enthusiasm from the cleft therapists to start using this treatment. And then hopefully, as well as that, once we have some more research, that will give people I guess the ammunition they need to persuade the funders or the commissioners or managers to fund the equipment, because obviously it's both things really, isn't it? We need to show that it does actually work. But on the basis that parents and children did seem to prefer the ultrasound, that's actually really useful as well, a really useful point to make, especially for children who've been coming to therapy for a long time. So please do put more questions in the chat, and I'm just going to kind of sum up, and then we should still have about 10 minutes for questions. So future directions, absolutely more studies. We're also looking at improving the actual ultrasound images as well. So I'm just going to show you a video here of one of my colleagues, Alan Wrench, who we work with quite closely, who's made where you can use some tracking of the tongue. I won't go into the full engineering of this, but just to show you that, I'll just play a quick video.
Two.
So obviously that's a different type of image, the one you've seen. And then another company in Kent who's making an ultrasound which superimposes a tongue on it, which I haven't got hold of this software yet. I'm hoping to get it quite soon to have a shot with.
La 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 e oi.
So obviously we would need to try that with some children to see how they react to it as well, so we've not tried that yet. So our challenges, we need to really understand the needs of NHS services when implementing the new technology, because obviously there's a cost of the ultrasound. It is much cheaper than electropalatography, because once you've bought it, you have it and you can use it with as many children as it's suitable for, but there might be some training needs, for example, that speech and language therapists might have. So we need to think about those things so that we can improve access to the technology to patients. And with the necessary time for speech and language therapists to train up, but also to deliver the intervention and to give children the number of sessions of intervention that they need to make that effective. And then, of course, more research to give us the evidence we need as well. So quick summary before we get some more questions. So the ultrasound is useful for learning these new speech sounds in children with cleft and children with other types of speech sound disorder. The ultrasound is easy to use, but we need more work to make it accessible. And we definitely need more research to show whether or not the ultrasound can help more children with their speech, so that we can start to use this across more places if it seems to be working. And that is our people who funded our research. So that's thank you to the people who gave us the money, but especially thank you to the children with cleft who came to the centre in Glasgow, and especially out to the University of Strathclyde for all these extra assessments. And their parents who obviously brought them there and did all the homework with them and so on. All right, so I will stop sharing my screen in case people want to, I think there's something in the chat, but I'll stop sharing my screen in case people want to kind of shout out other questions as well. You can see us a little bit more friendly. Okay.
I think I can also stop recording so that people feel more comfortable turning their cameras on.